That should work. Okay, great. So, sorry, you're gonna start over. Getting started. You've got your patient that's coming in and you've got your pediatric patient and, you know, what are you gonna do to prepare? So this is where our pediatric assessment triangle comes in. Okay, so it's our quick across the room assessment of our neonate, our infant, or our child. It allows us to quickly assess what's going on and be able to kind of efficiently manage that patient in a short period of time. So we're going to break down each part of the triangle because that's really important to be able to understand so that you can kind of have a really good comprehensive assessment going into it. So the first is appearance. So there's a lot of information that you can get from the appearance of a child. So think of it kind of as your quick neuro exam. PICLES is an acronym that helps you to remember to identify the important parts of the appearance portion of the triangle. So we'll break that down starting with T. T stands for the tone. So does your patient have tone or are they flaccid? Do they have an appropriate startle reflex? You want to really see, are they able to, you know, when you pick them up, do they tighten up appropriately and move, or do they not? And do they kind of flop back on you? So that's something that's really important. I is interactiveness. So are they interacting appropriately with you or with their mom or dad or whoever the family is that's in their room, or not? Are they just kind of ignoring their surroundings? It doesn't matter if you walk up to them, they don't actually notice. So that's a really important indication, is telling what your interaction is to the surroundings of that patient. C is how easily are they to console. So many kids might not be consoled by us since we're strangers, and that's completely understandable. But they can usually be consoled by their parents or whoever's caring for them. And so if they can't, then it becomes, well, why is that? Do they have an injury that's causing them so much pain that they can't be consoled? Or is there something else that's going on that's really causing them so much grief that they just cannot calm down? And that needs to be an indication for us. L is their look or gaze. Are they looking at you, making appropriate eye contact for their age, looking around the room purposefully? Are they unable to track at all? And when you look at them, they're just looking straight ahead, but they're not actually tracking with you. So those are all things that are going to make us concerned with this appearance section. And then the last is for speech cry. Are they crying or speaking appropriately, or are they making no noise at all? They have no verbal response to anything that you're doing, whether it be a verbal stimulation, a painful stimulation. They're not crying or speaking at all. So those are all the portions of the appearance triangle. And you can see here in this slide, this is a child that is flaccid. I mean, you can see that, you know, when you go to pick them up, they're floppy. They're not actually, they don't have that nice tone that you're expecting to see. So that is a big concern for us. Okay, so let's move to the work of breathing section of the triangle. So work of breathing is really important to be able to assess quickly. Respiratory status in kids is really the primary problem that you're going to have an issue with a child, is because they're having a respiratory distress problem. I mean, most of their issues stem from that. And so we really want to be able to quickly assess what their respiratory status is like and make sure that if there's something abnormal there, that we treat it quickly. So let's break it down a little bit. Abnormal breath sounds, all right? Are they grunting or wheezing? Grunting or wheezing can be an indication that they've got a problem in their lower airway. Do they have stridor, which is that feel like barking, squeaking sound, or do they have snoring respirations? Because that can be an indication that they've got this upper airway problem, something that's causing a blockage or a challenge in their upper airway. You don't always even need a stethoscope. A lot of times, if you're standing at the doorway and you're looking in, if you can hear the noises that that child's making from the doorway, then you know that this is something that you're going to need to intervene on. So it doesn't even always take going into the room and listening with your stethoscope. There are times when you're actually just going to be able to tell that there's something going on with this kid from the door, from their breath sounds. Abnormal positioning. You know those kids where they're sitting forward and they're really trying to breathe because they're having a lot of challenges. So that tripoding, that needs to be a concern for us. That sitting up tall, leaning forward to get more air, they're trying to open up that space. So those are things that are going to trigger in your head that something's not right with their respiratory status. Head bobbing is pretty scary when you see in kids. Their head's moving forward each time that they take a breath, and that's a clear indication that they're in some type of a respiratory distress that we need to intervene on. Retractions, and we're going to talk about retractions a little bit more on the next slide, but there are a couple of different types of retractions that you can see. But in order to see that, you need to get their clothes off. You need to be able to see what's going on with their chest and see where those retractions are occurring. But that's going to tell you if they're having some respiratory distress. they're gasping, that's imminent respiratory distress and needs immediate intervention. So that needs to be an automatic, let's hit go and move forward with patient care. And nasal flaring. Nasal flaring is a kid's way of trying to get more airflow in through that nostril. So if you have nasal flaring and then you've got any of these other symptoms of respiratory distress, that really should never be ignored. That needs to kind of be put together and say, okay, what's going on with this kid? But we need to start intervening because their work of breathing is really a challenge. You'll see in this next slide, it talks about a little bit of it shows a little bit of the different types of retractions that you can see. So that the I think I can put it out here. The suprasternal retractions are happening right above the clavicle. Your intercostal retractions are occurring in those intercostal space between the ribs. Substernal, you can see right under here, is right under your xiphoid process. And then your subcostal retractions are occurring below the rib. So when you start to see this, that's them really trying to pull so hard and using those accessory muscles to breathe. All right, circulation. So the last chunk of the triangle. It is a very important part of the pediatric assessment. And again, some of it you can see from across the way, but then there are a few things that you need to get a little hands-on. So we'll talk about that. Skin color. If they're totally bundled up, it's winter and they're fully wrapped up, you're not going to be able to see some of these things. So that's about getting them undressed to do that really good assessment. So what is their skin color? Got pink, gray, they pallid, are they blue? Are they mottled? Do they have mottling in their central core? Do they have mottling in their periphery? What does their central and peripheral cap refill look like? And how does that compare between the two? Are they the same? Is one a little bit slower? So is your peripheral a little slower than your central cap refill? Abnormal blood pressure, which we'll talk a little bit more about in the vital signs. Obvious bleeding or obvious signs of bleeding is definitely going to let us know that there's compromised circulatory system, compromised with their circulatory system. Because they're having a source of bleeding. And so with kids, they don't have a lot of blood volume. So if they lose even a small amount, it can be a large percentage to them. So that's going to let you know that you need to be concerned about their circulatory status. And then don't forget, if you have a pediatric patient and their heart rate falls below 60, even if you've got that palpable pulse, that's when in PALS we go ahead and start compressions, because once that heart rate gets below 60, they're just not able to compensate for themselves as much anymore. And we'll talk about that a little bit later when we talk about vitals as well. So here's a picture of a child with mottled extremities. So you see something like that, and it just needs to be a trigger like, all right, well, let me assess my cap refill. Let me see what else might be going on. Is there a reason that they might have mottled extremities? And then here's a good slide that just talks a little about cap refill. So if you were to do cap refill centrally, you typically want to do it right up on their chest. But if you're going to do it peripherally, you can either do it in their hands. So like in this photo here on the right here, in that palm, or you can do it on the bottom of their foot. And you just want to press firmly, and then you want to relax it. And then you want to see that that area that was blanched should pink up pretty quickly. And usually the ideal is less than 3 seconds. So if it's taking longer than that, then they have, poor cap refill. That's telling us that their circulatory triangle is part of the problem, and that we need to further assess to see what could potentially be causing that. So if we kind of bring it back all together, you think about all of the different pieces of the triangle. And when you do it individually, you're like, okay, yes, there is a problem with their appearance. And yes, there's a problem with their work of breathing, but their circulation was fine. Or their circulation and work of breathing was fine, but their appearance is okay, which usually appearance is involved in pretty much everything. So this is a helpful way of thinking about what your assessment findings mean when put together. So for example, if your child is normal in all of the categories, they're stable, and then you can just continue doing your full assessment and basic patient care. So you're like, great, my appearance, my work of breathing, my circulation, all of it's good, I can move forward. If they have positive symptoms in, say, their work of breathing category, but then they're normal in the other two, then that tells us, okay, they might be in some form of respiratory distress. We need to assess it further, and we might have to start some interventions, but it has not further progressed. If they start having positive symptoms in both appearance and work of breathing, though, then now we know we've escalated. And that's where you can see these two parts of the triangle. That's telling us we're in a respiratory failure, because that respiratory distress where you saw in the work of breathing section got so bad that it actually affected their appearance, which is kind of their neuro exam, meaning that they're starting to further decompensate. Now, Subsequently, if you have impaired circulation, so this bottom part of the triangle here, with or without a change of appearance, then they're in a state of shock. Because, you know, with kids, as soon as their circulation starts to change a little bit, they're usually in some form of shock. We just have to do a good job at figuring what's going on. So there's a couple of different things that they could be in. Hypovolemic shock, septic shock can be a big one in pediatric patients. So it really makes you stop and think what's going on with this kid that's making their circulation compromised. If only, let's say only their appearance is affected. Maybe they have something going on with their CNS or a metabolic complication. Could they be a new type 1 diabetic and they didn't know, and so now they have altered mental status? Could they be a child that overdosed on something that they found in the house, and now they have that altered mental status? Because remember, appearance is kind of like your quick neuro exam. So there are reasons that you could potentially just see a change in your appearance. But if all three are messed up, okay, so you've got appearance, work of breathing, and circulation, all three are not normal, then that child requires immediate intervention and stabilization, because they're in both cardiac and pulmonary distress and failure because all of their systems are affected. So again, this is a really helpful way to kind of bring all of those pieces together in a logical format, because we've all been in the situation where we look across the room and we see either a child or an adult and we say, oh, that does not look good. And it's because of all of these things, and we just don't always put it in the best of words. So this is a really nice way for kids especially to do a quick assessment, to be able to validate what you're seeing and feeling when you look at this kid initially. So getting some more information. We do our across the room assessment, our pediatric assessment triangle, but we should probably get a little bit more information. So what does that look like? Sample history. I really like sample histories. Not everybody uses this format. Other people will use different ways to get a full medical history, but I think sample really encompasses everything. It's an easy way to remember all of the important parts that you need to ask any patient that you encounter. So it goes through your signs and symptoms. So what's wrong? What made you call? Your allergies. Do you have any allergies? What happens when you have those medications or you encounter those things? Medications, are you taking any? What are you taking them for? When did you last take them? This one gets forgotten a lot, especially sometimes with kids. They have a fever, maybe they've been getting some Tylenol, and then it can be easy to forget to ask mom, hey, when was the last time you gave Tylenol? If it was just an hour ago, we don't want to do it again. But if it was 6 hours ago, we could. P is for your past medical history. So do you or does the child have any medical problems? L, last oral intake, when did they eat or drink? And then E is events leading up to the illness or injury. So it's just a really nice way to encompass everything. And don't be afraid to ask parents lots of questions. They have a lot of information, and some things they might not actually think are as important as they are. So really feel free to ask as many questions as you can. Then we want to start thinking about our vital signs and what's important. So there's a lot of resources out there. You can get apps on your phone that have vital signs. There are badge buddies that groups will send out that have vitals for pediatric patients. You can actually just look down at your badge and see. There are reference cards, like these AHA reference cards that we have on our code cards here, but that can be a quick, easy way to be able to see what your vitals are supposed to be. So we do know in general, and I will be the first to tell you that I will very easily forget what normal vitals are for different age groups, because we don't see it terribly often. You kind of have to pause for a minute and think, you know, what is this supposed to be? So we know that kids' heart rates tend to be higher than adults, right? So for me, when I see a kid that's consistently has a heart rate over 160 and I don't really have a reason for it, then that usually tells me that I need to do a little bit of assessment. Now, sure, you've got your newborns, so you can see here they can be up to 205, but usually once they start getting a little bit older, you can see here this is 100 to 190, but 190 is usually like I'm angry, I'm agitated, I'm crying, I didn't get what I wanted. But when you've got a resting child that's consistently 160, 170, 180, and you're not entirely sure what's causing that fast heart rate, that's where it needs to make you stop and pause. We also know respiratory rates are higher in pediatric patients than adults. Again, my cutoff there tends to be about 50. If I see a child consistently breathing over 50, especially if they have an increased work of breathing, like we saw in that pediatric assessment triangle, then I start getting a little bit more concerned about what's causing this tachypnea in this child. So there was a paramedic that I worked with that taught me a really quick trick to help figure out what appropriate blood pressures are. So if you want to get the average blood pressure for a child, so this is average, not the low end, you would take 90 and you add their age in years times 2. Okay, so if we have a 2-year-old, then we would do 90 plus 2 times 2. So 90 plus 4, which is 94. So you would expect that their average systolic blood pressure for that 2-year-old would be about 94. All right, but let's say you have a pediatric patient that you've identified as an extremis. They've got increased breathing, they have poor capillary health, they've got some mottled extremities, and you're starting to move down the track of, do I need to do a fluid bolus? Do we need to start a pressor? You know, what number are we actually comfortable with? Because 94, that's an average, right? So that's kind of like saying in an adult, oh, you know, 110 or 120 systolic. We don't necessarily need to intervene on that, right? Kids are different though, because they can range depending on their age as to what that lower end of the blood pressure is. And adults is easy. It tends to be either 90 systolic or I'm at the 65. So to figure out with kids, rather than taking 90 plus their age times 2, you take 70 plus their age times 2. So for that same 2-year-old patient, it was 70 would be 70 plus 2 times 2, which is 4. So 70 plus 4 is 74. So we would know that 74 is our bottom number that we want to see that systolic. So if we're approaching or dropping below 74, then we need to do some type of an intervention, because now they're hypotensive for their size and their age. And you can see here, it says that a little bit on this PAL sheet as well, definition of hypotension. But just be careful, because some of the resources that are out there will do the 90. So it kind of tricks you into thinking it's okay, or they'll do the 70 and not really tell you that that's hypotensive. So keep it in mind when you're trying to figure out what the appropriate blood pressure would be for the patient that you have. Glucose. Oh, glucose is so important. So I can't stress this enough that a glucose needs to be considered a vital sign in kids, especially the ones that can't easily talk to us, or the ones that have a GCS of less than 15 and are altered. So any type of minor alteration where they're not acting appropriately, you should be checking the sugar. They have a really limited compensatory mechanism and much higher metabolic rates than adults. So they actually burn through their glucose scores and become hypoglycemic even faster than in adults, especially when they're sick. And their livers are more immature. So in adults, we have a backup glucose store if we become hypoglycemic in our liver, and that's glucagon, and then we start burning that instead. But kids don't have those glucose stores, especially not the same as adults. So it becomes really easy for them to get hypoglycemic. So when in doubt, any kid that is not a full GCS of 15 or has something where you're just like, they're just not acting right, check a sugar. Super easy to check a finger stick just to make sure that that's not part of your problem. Temperature is another really important thing that I think sometimes is easy to forget, especially if you've got a little one that's finally settled down. And then now you have to do a rectal temp on them, and you know that it's going to get them angry and agitated again. So it's a really important though. And the smaller the child, the less compensatory mechanisms they have in place to actually be able to thermoregulate themselves. And that's why we use the infant warmer in our babies and infants, because they have a really large surface area compared to their weight, and they have pretty minimal subcutaneous fat and pretty thin skin. So they don't have the ability to shiver, to sweat. Their vasoconstrictive mechanisms are really poor at this time, so they can't regulate their temperature as well. So that's why it's so important that we check it, and then we do something about it if we find that it's too low or subsequently too high. So you want to remember that rectal is the most accurate, but axillary can actually be the next best in kids if they have a hard time following instructions for obtaining an oral temp. You want to make sure that they haven't had anything to eat or drink recently, to get that accurate reading. But if they're not able to close their mouth and keep it closed, then an oral temp isn't going to be the most appropriate for them, and axillary might actually be better. And then the little ones that don't have a fever, don't be afraid to swaddle them up, keep them nice and warm after you finish your head to toe. Because remember, you want to do your assessment while they're don't have all those clothes on, so you can actually see their skin and you can see what's going on with them, so that you can get a little bit more information, since they can't talk to us and tell us necessarily what's going on. All right, our weight, super important. We want to check a weight on every single kid that we have. Regardless of what's going on, we should know what their weight is, because everything is weight-based for kids. Medications, fluids, your defibrillation jewels, your airway equipment, IVs, OG tubes, Foleys, everything is weight-based. Don't use pounds, always kilograms, always kilograms. And like I said, even if you think they're healthy, still get a weight, because you never want to be caught without having the information that you need if something changes. If you work pre-hospitally and you don't have access to a scale, then you can use your Broslow tape to give you a rough weight, especially if parents haven't had a recent weight for their kid, and bring it to the Broslow tape. So Broslow tape, I'm sure everybody's familiar with it. It's a pediatric emergency tape, helps you to determine the weight of your patient based off of their height. So you can see here in the picture, you're going to take that tape and you're going to lay it next to the child, and you want to measure it up. So you've got the measure from this end, and you want to hold that to the top of their head, and then you measure down to their feet. All right, so wherever their heels hit on the tape is your estimated weight. So like, let's say if we came down here and it fell halfway through the blue, you can see there's actually a couple of different numbers on blue. So you'd want to see where their heel fell. Let's say it fell on 20 kilos. And so then we would know, okay, 20 kilos is our number. Now, there's a lot of information on here as well about medication doses, equipment sizes, which is a really important one. It's a really great tool. So if you have any sick kiddos, really recommend that you take this out and you just put it next to them for the resuscitation, because even if you get that number, it still has a lot of other information that could help you through the resuscitation. Our ED has them. They're actually in plexiglass, and so you can just go ahead and lay it right on the stretcher, and we just finished doing this. So I don't think we've gotten to use it yet, but you can lay it right on the stretcher, and then that way it's always spread out and flat and right there for you. And every EMS truck should have them. So they're pretty easily accessible, but any kid that you have, definitely keep this in mind, because this is a great piece of equipment to have. Okay, so adults versus kids, they're not the same, and that can make the treatment a little bit more challenging, and I think sometimes a little bit more intimidating, because I think all of us can agree that we see way more adults than we see of kids. And so kids tend to be the more intimidating group. So I'm going to go through just a couple of the big differences between adults and kids to just try to give you a little bit more confidence when working with some of these systems. So the first we'll talk about is their head. Okay, so infants and children less than about 8 years old have heads that are disproportionately larger than the rest of their body. And one important thing that's different with kids is their fontanelles. All right, so they can give you a lot of information. So you can see here, you've got your posterior fontanelle, and then you've got this anterior fontanelle. And it's an open space, and it starts to close. So your posterior starts to close about 2 months, but your anterior is actually doesn't close until about 16 to 18 months. So this one can give you a lot of information. And what happens is you just kind of feel the top of it here. And if they are normal, then it's just going to be flat. It's going to be flat, it might be a little soft, but it's flat. If they're dehydrated, you're going to notice that it's sunk. So it's actually a pretty significant sinking down that you would feel. And that clues you in on, okay, well, they're under resuscitated volume wise. So does that mean that they were hypovolemic from vomiting or from diarrhea or for something at home? They're obviously sick and they haven't kept up with their fluid intake. So dehydration is a big concern. So it's going to tell you a little bit there. If it's bulging, so you rub across the top and it's a big bulge right there that goes past that scalp, then that's going to tell you that you've got increased intracranial pressure. So it can give you a lot of really good information. So always just kind of anyone under about 2 years old, feel free to just feel on the top of their head and see if you can tell a difference between the fontanelles. Our neuro exam. We can't do really a traditional neuro of where are you, what's today, who's the president, that type of thing with our kids, because they can't answer those questions. And some of them, they are not even speaking yet. So they really can't answer those questions. So AVPU is a really important acronym that we want to use with kids. It can be really helpful in assessing their mental status. You want to use it in kids that are really about 6 or under, or if they can't answer the normal questions, like I just said, time, place, and the situation. So when you break down AVPU, A is alert, right? They're active, responsive to parents and staff, interacting appropriately. Everything looks good. Your normal kid. Your V would be that they're responsive to verbal stimuli only, okay? So they're not really looking around or participating much, but if you call their name, they wake up, they look at you, they interact appropriately. E would mean that they're responsive to painful stimuli only. So you either do, a chest rub or squeeze a fingernail, and they respond to that, but only that. And then our U is unresponsive to any type of stimuli. So using AVPU, and sometimes people use that for adults as well, but using AVPU with kids is a really nice way of quickly getting an idea of what their neuro is. Airways are very, very different. There's quite a few differences. So just to start breaking some of them down, and for anyone that's a true airway provider, meaning you're doing intubations in the field or within the hospital, you really want to make sure that you kind of understand the differences between the two, because it does change your plan and your management. So to start, kids have a really big head, okay? And so it makes positioning challenging to get that best view. So you can kind of see here that big head is starting to change the angle when they're laying flat versus how an adult might be. So they can really easily occlude their airway, which you can see right here, especially if they're minimally responsive. So padding with towels under the shoulders can help to raise this area, this shoulder area, so that it gives more space for that head, and then it makes that airway a little bit more open. So that's one thing that we can sometimes see. Their tongues are relatively large for their mouth, and they don't have teeth that kind of help to keep it in place. So it can be easier for them to obstruct. So when you're actually putting your laryngoscope blade in, you really want to make sure you've got good control of that tongue, because it can be really floppy and really get into your way. The cords tend to be a little bit more anterior, so a little bit more forward. So when you're trying to get a view, it can be challenging. So, if you are going in for an attempt, you just want to be really patient and try to visualize your landmarks as you enter your airway, and then you can reposition the head as needed. So while you've got your blade in, you take that right hand, you can kind of reposition the head a little bit, because it is so easy for them to occlude, and it can actually give you a better view that way. There's a couple of different blades. So we've got our Miller blades and our Mac blades, right? Our Millers are straight and our Macs are curved. Miller blades are typically recommended in pediatric patients, because what happens with the Mac blades, that curved blade, is that the goal is to put the blade into the vallecula. So it's that space above the epiglottis. So it's kind of hard to see here, but you can see the epiglottis on the bottom right of this adult. And then the space above it, that you can't really see on the picture, that's your vallecula. And so what happens is you're trying to get that Mac blade into that vallecula, and then it lifts a ligament that's there, and that's what lifts your epiglottis. Well, in kids, that ligament isn't fully formed. So pretty much, I think about 2 years old is probably the cutoff for that. But up until 2 years old, that ligament's not formed. And so if you actually tried to use a blade to intubate a child and put it into the vallecula like with an adult and lift, because that ligament's not formed, it's not going to lift. So the epiglottis is still just going to stay there and be floppy. So instead, what we recommend is that you use a Miller blade. Miller blade's the straight one. And what it does, as you can see in this top pediatric airway picture here, is that the Miller blade goes directly, scoops up this epiglottis. Here it doesn't look like it's doing a very good job with it, but the idea is that it's supposed to scoop up that epiglottis to be able to get it fully up and out of the way, rather than getting into the ligament and pulling it up that way. Now, you can use a Mac blade still if the Miller's unavailable. You just want to make sure that you hook the epiglottis again and lift it so that you can get that view. And it also, a Miller blade can make it a little bit easier when you have a really small mouth, because when you don't have a lot of space to work in, the Miller blade can actually be a little bit easier for you. There's a really good reference at the end of all of this, but I'll tell it to you right now, but called the Airway Jedi. And I really recommend going on that website. It's Dr. Witten is an anesthesiologist that has tons of resources, information about intubation, various intubating situations, techniques. There's an article where some of this came from called Intubating an Infant or Toddler. That's really phenomenal, goes into depth about blades and techniques, and et cetera. So I would really recommend you doing that, especially if you're intubating, potentially intubating kids. So what about our ET tube size? So let's say, I'm working in the ED, my provider says, hey, we're gonna go ahead and get ready to intubate. I've got respiratory there with me, all of us are there, and then we're like, well, how do we know what size ET tube to pick for this kid? Couple of things. Go to your Braswell tape. Braswell tape will tell you what size ET tube. But let's say for some reason, you know, in the crazy world we live in, the Braslo tape is something that you can't reach readily available, and you're staring in front of the airway drawer and you're like, what do I need to do? I had one paramedic that I worked with. He used to tell me a 4 gets a 5. So a 4-year-old gets a 5-0. And then he was like, just kind of go up or down from there, which is actually a great technique in some situations. But there are definitely other ways, especially if you don't have a 4-year-old, that can help you figure it out. So one thing that you can remember is if you take their age in years, divided by 4 plus 4, it'll give you a rough estimation of what size their ET tube should be. So when trying to determine an appropriate depth, a rough start from there is to take the size of the ET tube and multiply it times 3. So that would mean if we put a 5.0 ET tube in, we would expect it to be roughly 15 centimeters around the teeth. But keep in mind that the smaller your ET tube and the smaller the patient, the easier it is for it to dislodge with very little external stimulation. So even in really small patients, think of your infant level, just extending their neck back and back down can be enough to extubate and then re-intubate. So that's why it is important still, if we can, to get that chest x-ray, make sure that it looks like it's in okay position, but it's not necessarily required. I think sometimes different providers have different feelings on doing that, but we still have end tidal, right? We still have our breath sounds that we're assessing, our missing in the tube. We should be getting good return on our vent. We have other things that we're able to look at. But Airway is very different. So Airway Jedi is an awesome website. Okay, respiratory system is also a little different in kids and adults. So the chest is much smaller, obviously. So sounds can much more easily transmit across the chest and abdomen. So when you're listening, it can be really difficult to listen over the lung fields and say, yep, our ET tube is definitely in, or yep, we've got really good bagging, I've got chest rise and I have good breath sounds, because it's such a small area. So you want to make sure that you confirm, you know, your tube placement with other metrics. So do I have end tidal? Do I have positive just chest rise? Do I have a positive increase in my SpO2 and my heart rate? So just don't get bogged down in just listening to those breath sounds. If everything else is telling you the tube's not in the right place, it's not in the right place. There's a lot of referred noise in that area. The chest wall also is a lot more compliant in kids than in adults. So when we're ventilating, it can be really easy to overventilate. So what you want to do is, if you have the ability to watch the pressure, so some of the BVMs actually have manometers on them so you can see what the pressure is when you're bagging, you want to keep it in the green. If you don't have that in your bagging, you just want to bag until you see chest rise. And it's just very little chest rise. It doesn't need to be a huge motion. It should be something that's actually pretty subtle and pretty small. And then again, you're going to see that increase in your SpO2 and your heart rate. And you know that you're oxygenating and ventilating, but you're not overdoing it. And because it is such a compliant chest wall, and rib fractures are actually less common in some traumas, but you can still have pretty extensive pulmonary injuries underneath, even without seeing those overlying rib fractures. Where in adults, you tend to see rib fractures and think, oh, okay, there's probably a pulmonary injury. With kids, you tend not to see the fractures, but they can still have that injury. So we just want to be really cautious of that. Another thing that's really easy with kids, if we're manually bagging them, is that we can cause a lot of buildup of air and gas in that stomach. And this accumulation of gas can actually impinge on the ability of the chest and the diaphragm to function appropriately, and it reduces your ability to ventilate them, right? So if their stomach's getting really big, it's pushing up on their diaphragm, it's pushing up into their lungs and their heart. Now their cardiac reserve is a little bit less because their heart can't expand and contract as well because of all this pressure. Your lungs, you're having trouble filling because all that pressure from down below and that gastric bubble is starting to come up. It decreases the return of blood to the heart, so it's worsening the cardiac status. So if you're having a point where you're resuscitating a child, and let's say you had been bagging them manually for a while, you get them intubated, and then you're still just having some challenge in ventilating, drop an OG tube, decompress that stomach, get all of that air out, and then it's going to give the patient a lot more room to be able to have their lungs expand and to improve their cardiac output. So don't forget how easy it is to overbag and get a lot of air into that stomach. And speaking a little to the cardiac. So kids' compensatory mechanisms aren't super great in their cardiac system. They're very rate dependent. So that means that their cardiac output is really heavily dependent on their heart rate. So they can't compensate as well as adults can. So because of this, a bradycardic child has a significantly reduced cardiac output and can rapidly decompensate and eventually get into cardiac arrest. Hypoxia, interestingly though, is the most common cause of bradycardia. So if you see a child that has a really low heart rate and you're thinking, oh, cardiac, actually you want to be thinking respiratory, because hypoxia is the #1 cause for bradycardia in kids. So we should be treating it with 100% oxygen, ventilation. And this is also why we start compressions if our heart rate is less than 60, because once it drops below 60, they don't have those compensatory mechanisms to be able to do what it needs to do to keep that cardiac output up. And so their circulatory system starts to collapse. So when in doubt, low heart rate, that's when we do the below 60 CPR, but we always want to focus on that respiratory component because that's primarily what the cause of the problem is going to be. And then we talk about blood pressure. We talked a little earlier about how do we actually determine a blood pressure, but it's not always reliable, especially if you've got children under the age of about 2. It can be really difficult to actually get a legitimate blood pressure on them. So you really want to use your good assessment skills to determine their perfusion status if you can't get an accurate blood pressure. So that's your cap refill, assessing your skin color, turgor. You want to look at that modeling and see, where you feel that your perfusion level is. Again, cap refill, I'm all about cap refilling kids, is a really good way to do that quick cardiac assessment. So you want to, again, look on the chest, and then you want to look on the arms and legs, hands and feet. If you do have somebody with an impaired cap refill, then you want to start looking for signs of maybe cyanosis, additional modeling, and that's that splotchiness that we saw earlier. And that's going to give you a little bit more information as well, again, because blood pressures aren't always super accurate, especially in your really little ones. Renal system. All right, most important thing to remember here is just that they tolerate dehydration very poorly. They're very easily prone to dehydration though, because they have a really high insensible fluid loss. So they've got a large surface area relative to their weight. And they aren't really able to concentrate their urine as well as with adults. So a day of vomiting and diarrhea can be enough to put a child at risk for hypovolemic shock. So that's where you have to get that good history from the parent. So when we're talking about the renal system, we want to know about feedings, wet diapers, abnormal bowel movements. Have they been having a lot of diarrhea? When was the last time you changed their diaper? So when was the last time they voided? When they cried, did they make tears? So parents usually know all of these things, but they don't always think that all of it's important necessarily to tell you right off the bat. So you really want to start getting more information from them about this. Okay, we're going to talk about a couple of the most common disorders. And again, this isn't an exhaustive list, but it's just some of the most common things that we tend to see pre-hospitally and in the ED. So trauma, right? Trauma, we kind of approach similarly, adults and kids, because what we want to do is a nice systematic approach. Either if they have a known or an unknown injury or mechanisms capable of producing injury, should always include a rapid survey for all potential interventions, consideration of airway management, IV access, fluid medication administration, prevention of heat loss, especially in our kids, prevention of heat loss. But again, our good really ABCs or trauma ABCs. Initial priorities in pediatric trauma patients, though, should always be really focused on that respiratory system. So airway, oxygenation, ventilation. Circulation and neurological status are definitely important. But like we talked about before, respiratory problems tend to be the cause of cardiac problems. So we really want to make sure that we're supporting that respiratory system and making their airway patent, oxygenating and ventilating safely. And then we want to identify the injury that has the highest probability of being life-threatening. Same with adults. So let's say you have a child comes in and you know that they have a head injury and you need to go to CT because you're not sure if you have potentially a head bleed, but they've got a really significant abdominal injury and they are hypovolemic now and they're becoming hypoxic. And so it's just about prioritizing what do we need to do. There's not a lot of facilities that have high-level pediatric EDs or PICUs in this area. So we've got Dartmouth, UVM has a PICU, and then moving further down south, we have quite a few in southern New Hampshire and definitely in Massachusetts. So it can be challenging in our area to figure out where the best place is to send these kids. Do we go directly? Do we bypass a local center to go direct to the trauma center? Do we not? Do we stop because we need additional assistance? So I would say if you ever have any, and this is just by Danielle, but you have airway or respiratory compromise, you're really struggling to get that airway taken control of, then you need that extra help. Then that's absolutely appropriate to go to your nearest center, and then it kind of depends on your department and what the expectations are as to whether or not you bypass or not. But it is really important to keep in mind that while we do a similar approach like an adult, there can definitely be some differences. They've got less blood volume, like we talked about earlier. It can be a little bit more challenging to get access. Some of the airway manipulation can be a little bit more challenging. So we really just want to be on top of the ball when it comes to traumatic injuries in kids. Pediatric bones can be fairly supple. So if you notice that you've got broken bones in our pediatric patients, you really want to be concerned for underlying injuries. But we also want to try not to get bogged down in distracting injuries, which can be really easy to do in kids. And if we need to do fluids, we would want to consider 20 mLs per kilo of warm crystalloid. But if we were doing blood products, and it tends to be about 10 mLs per kilo of blood given with the fluid warmer, because again, kids really struggle to keep their heat, to retain their heat. We want to make sure that they're warm as possible. So fluid should be warmed, blood should be warmed, warm blankets. Once you get them trauma naked, as everybody calls, to do your full initial assessment, you want to make sure that you get nice warm blankets on and keep them covered up to the point where if you need to use a bear hugger to keep that warm air in, that's okay. DKA. So there's usually two types of DKA patients that you'll see. The ones that know they're diabetic and the ones that don't, especially with kids. That's usually what ends up happening. So the most common symptoms that you're going to see are fatigue and the 3 Ps. So you got polydipsia, polyuria, and polyphagia, right? And so parents tend to comment like, oh, they've been eating and drinking a lot more usually, and they're peeing all the time. And it seems like they're losing weight. They just can't keep anything on them. They're always tired. So if you've got a kid that comes in and parents has any of those complaints and they just look really exhausted, and you're like, oh God, you don't look like how a kid your age is supposed to look, like, you know, awake and alert and interactive, that needs to be a red flag that we might need to dig deeper. And that would involve doing a finger stick, whether you're pre-hospital or in triage in the ED. You know, it's a quick and easy way to be able to assess what's going on in that moment. So your goals for DKA treatment are always going to be revolving around fluid resuscitation, insulin, and electrolyte replacement. Remember that most patients that are in type 1 diabetes that go into DKA, they have some kind of other illness, and that's what kind of triggered and put them into DKA. So keep digging for maybe a background cause. So did they have a UTI? Have they had a stomach bug? Something? Have they had just a common cold? There's usually some kind of illness that triggers their sugars to become really uncontrolled. And keep in mind that these kids tend to look really crummy. They're really tachypneic, so their respiratory rate is definitely elevated, and they're lethargic. So when you look at them, it can be really tempting to want to intubate them because their mentation is definitely poor. They're really tachypneic. It looks like they're working really hard with their breathing. But you want to keep in mind that they're altered because of their severe metabolic derangement, which hopefully we're now correcting with insulin, electrolytes, IV fluids. And that tachypnea is a compensatory mechanism to blow off more CO2 because they're so acidotic that they're trying to improve their pH. So we tend to not want to interfere too much in their respiratory status, just because they're doing such a good job on their own, blowing off as much CO2 as they can. So we tend to just closely monitor and intervene if necessary. And if you need to intervene, that's obviously fine, right? But we really just want to make sure that we do all of the supportive measures really well to get that metabolic process turned around. And they should be monitored. Usually they have to be monitored in a PICU until their anion gap closes, their metabolic acidosis resolves. And those are some other things that we can always talk about in another lecture, because that could be a whole topic. There's actually a DKA one coming later this fall. There's a little plug-in. But these are pretty scary kids when you look at them. They're very sick individuals. And so, you know, you just want to be very cautious, but then also frequently monitoring and checking in and seeing if things are improving, which they should start once we start treatment. Okay, Airway disorders are always kind of terrifying in kids because they can't really talk to you about what's going on most of the time with our little ones. And then, you know, there's a lot of things that can be a problem in airways in kids, and everything is significantly smaller. It can be more challenging with the intubations if they need to be intubated. And so here are a couple of classic things that we can see with upper airway disorders. So we've got croup and epiglottitis are kind of the two big ones. So I'll break them down. So croup, it's an upper respiratory infection typically caused by a virus, fairly common, affecting about 15-ish% of kids at some point in their lives, usually striking somewhere between 6 months and 5 years old. So there's a pretty big window. It has been a little less common due to vaccinations, but the infection itself can lead to swelling inside the trachea, which interferes with their normal breathing. So that produces that barking cough. They have stridor, so that high pitched when they're trying to breathe, and a hoarse voice. And they can also have a fever and a runny nose. Symptoms can be pretty mild, but they can also be severe, and it tends to be actually worse at night. So a chest x-ray, if you look here on the left, you can see what they call a steeple sign. And so that is a classic sign, narrowing of the airway that you see in croup. So you can see how small it actually gets. So the goals here are to keep the child nice and calm. So that means not doing anything to them that won't directly or positively impact their care. So if they need to have something done, obviously we're going to do it. But if they don't, so, you know, we can even think like IV. They need an IV right now. Maybe not. Maybe we can hold off and we can put them in a position of comfort. We can give them cool humidified oxygen. If it's severe enough, steroids like dexamethasone can definitely be considered. And we can also consider doing racemic epi if they have stridor, especially if at rest. If they have stridor while they're sitting relaxed with mom, then we definitely want to consider potentially using racemic epi to see if we can open up that area a little bit more. Okay. Moving to epiglottitis. This one I think is quite scary to see in kids because it's something that's really difficult to manage in the acute phase. So it's an acute infection and inflammation, right, of the supraglottic soft tissue structures that lead to airway occlusion. So you can see in this bottom right picture, all of that angry mess, okay? And that is the potential to actually completely occlude the airway, which would be a true emergency. And so if you're trying to diagnose a child before you have any of this imaging, because right, you're not going to have these images, you're not going to have that x-ray right off the bat, you want to think of the 3 Ds. So that's drooling, dysphagia, and distress. So they're usually leaning forward, they're drooling, they can't swallow, and they're in clear respiratory distress. So in early stages of this, they might just say, I have a sore throat, I'm having trouble swallowing, or mom might say, you know, they haven't been eating very well, they've been drooling a lot more, they've got a fever or cough. And these can be common symptoms for a lot of different respiratory diseases. But then in the later stages, that's when you start seeing them leaning forward. They're drooling because they can't swallow. And then if you do that x-ray, you can see here, you almost see what they call that thumbprint sign. It's almost like you're pushing your thumb right into that area. And that's because the epiglottis is thickened with inflammation. So antibiotics and NSAIDs could be helpful for that inflammation, but definitive care usually requires monitoring in the PICU. If they have to intubate and you're at an area with a PICU, then usually they would like to wait as much as possible to get that inflammation better under control. But if you can't wait, if they're in respiratory distress, then the intubation has to include the most experienced provider, often occurs in the OR, potentially doing an awake intubation technique. So then that way you have the ability to hopefully have a little bit more control. If you're having a challenge with the intubation, you didn't paralyze that patient, and then have the preparations to actually convert to a surgical airway if needed. And that's why it can be really scary pre-hospitally or in a small hospital such as ours to have a kid with epiglottitis, because it really significantly narrows down your options. You could tell a supraglottic airway isn't going to be helpful here, right? Because there's so much swelling right over the cords, and a supraglottic airway kind of sits over that area, but it's not going to be able to get that air movement you need. So it really starts to limit you. So this is one where you just want to let them relax. You don't want to agitate them. You want to get them in a position of comfort. Like I said, antibiotics and NSAIDs can be helpful, but we really want to get them up to a PICU for close monitoring and potential airway management. And then we got lower airway disorders. We talked about the upper, a couple of the lower. So two of the big ones for kids at least is bronchiolitis and asthma. So bronchiolitis is usually caused by RSV, usually happens in kids less than 2 years old. There's a blockage of the small airways of the lungs. They have symptoms like fever, cough, runny nose, wheezing. Severe cases, you can see that nasal flaring, grunting, or retraction. So going back to our pediatric assessment triangle, you're going to see that work of breathing start to increase. And our treatment really focuses on symptom management, right? Oxygen, IV fluids if they're dehydrated, supportive care, position of comfort, making sure that they are properly oxygenating and ventilating. And then asthma. Asthma can be a pretty tricky thing to manage. It's a chronic condition, but you can have intermittent acute episodes, right? And those are what tend to be or can be severe and life-threatening. So they can be triggered by things like infection, exercise, inhaling irritating substances can be enough. And an acute asthma exacerbation can actually trigger an allergic response. So it causes inflammation of the respiratory tract, bronchoconstriction, hypersecretion of the mucus, so a lot more mucus buildup, and that causes varying degrees of airflow obstruction, right? Because you can see here how when things start to wall thickens and now we're inflamed, and then if we fill that with more mucus, then it significantly narrows our airway. So we can see shortness of breath, right? We can see wheezing, cough, tightness in the chest, air hunger, and it can be challenging depending on the severity because it can be really hard to turn it around and manage. So nebs like albuterol and Atrovent can be really helpful for treating bronchospasms in mild to moderate cases. Epi, given IM or IV, depending on the severity or what your accessibility is, to be considered depending on the severity of your symptoms. Steroids and MAG can be beneficial as well. Ideally, we want to try not to intubate, so we can actually consider high flow, we can consider non-invasive positive pressure ventilation, but once we intubate and kind of take over that respiratory process, it can be really difficult to ventilate them because we're no longer using that negative pressure where our diaphragm drops and we kind of pull air in. We're doing positive pressure ventilation now where we're trying to force air into these lungs that are tight and constricted and not wanting that to happen. So it can be really difficult ventilation-wise to manage these kids. So like I said, high flow and things like CPAP can be really, or BiPAP can be really beneficial in turning these kids around without having to intubate them. Seizures we see, I don't want to say frequently, but I think it's a fairly common pediatric disorder that we see. And they can be really kind of scary because a lot of times they're happening when we're not really prepared yet, right? Like it always seems like kids seize during the transfer of care or out in the waiting room when they first arrive, or when they're in a totally different area like urgent care and you're not expecting it. So seizures are what? They're characterized by sudden uncontrolled electrical disturbances of the brain, and it causes either a sensory perception or a motor activity change. All right, and there's a couple of different types. We've got generalized. So that involves abnormal activity in both hemispheres of the brain and is accompanied by a loss of consciousness. We've got partial or focal, which is abnormal activity located in one hemisphere. And then partial seizures can also be broken down into a couple different categories. So they can be simple, where they maintain consciousness through it. They can be complex, where they have impaired level of consciousness. We can see different muscular patterns. So we've got our tonic seizures, so that rigid trunk and extremities, our clonic seizures, so that symmetrical rhythmic jerking, tonic-clonic, where we've got the rigid and then the jerking, atonic, where they just lose their tone, and then myoclonic, where they have these brief shock-like muscular contractions. So there's a lot of different things that we can actually see. And sometimes that can make it challenging to determine whether or not somebody's actually having a seizure. Most seizures tend to be short in duration, not all, and that's why we want to try to measure it the best we can. If you see somebody start to seize, you want to look at the clock and see what time it is, and so you can track roughly how long that seizure lasts. And a lot of the patients experience a postictal phase, right? We'll talk about that a lot, where they can have a deviated gaze, they might have been incontinent, they have altered mentation, they're difficult to wake, they might only respond to painful stimuli and have a respiratory depression or diminished airway reflexes. And so that's why when you take PALS courses, they have seizures listed as a disordered control of breathing disease, because it can cause some significant respiratory complications. So again, kids, respiratory, really important. So that's what we want to make sure, that their airways patent, they're breathing normally, and they're ventilating and oxygenating. And there's a lot of causes for seizures, right? It's not just one thing. They could have high or low blood sugar, certain drugs, especially if they get into drugs in the house, concussions, epilepsy, fevers. If you know what the cause of the seizure is, then that's what we want to treat. So if we know that they had a seizure because they were hypoglycemic, then let's correct that. If we know that they had a seizure because they are febrile, let's correct that. So sometimes it's not always just about the seizure management, but also what caused the seizure and what can we try and reverse. And we might not have all that information right off the bat, but that's what we want to strive for, is to figure out what the cause of this was. But your initial treatment of seizures does focus on stopping it if they're actively seizing, usually with a benzo such as Ativan or midazolam, and then supportive care if they're in a postictal phase. So a good position so that their airway is patent, oxygen if need be. If the child's not actively seizing when you either get to them if you're pre-hospital or in the ED, then that's when you want to start considering what my potential cause was for my seizure and how can I start to treat that. Obviously, if they're actively seizing and you feel that we need to break that, then that's when you would want to go to your benzos. And then further treatment can include Keppra and Depakote, especially if there's not an easily identifiable cause that you could treat or reverse, like hypoglycemia or like a febrile seizure. Distributive shock is something that we see fairly commonly with kids, and really it's septic shock, but it's also a little bit of hypovolemic shock kind of mixed into it. But we're going to talk more about hypovolemic shock in the next slide. There's a lot on this slide, but what I can tell you is that the Surviving Sepsis campaign has a really good algorithm for kids. So that's something that I would just go ahead and review, because sepsis is fairly common form of distributive shock that we see in PD patients. And it is life-threatening. The body is having a response to infection, and so it causes injury to its own tissues and organs. And so you can see fever, increased heart rate, increased respiratory rate, altered mental status. So when you look at the screen here on the left, that initial algorithm that I was just talking about, you can find it on the Surviving Sepsis website, which is right here, down here. You can just go ahead and Google Surviving Sepsis, but it does have a lot of information there that's good to review. Another thing that I think is really helpful is you've got QSOFA and you've got SIRS criteria. I think we throw that out a lot, but we don't really actually talk about it or go into depth of it too much. So QSOFA criteria, it's a pretty simple and objective score that allows you to identify patients that are with suspected infection that are a high risk for a poor outcome. So the three variables that it includes is your systolic blood pressure, so below minimum systolic blood pressure for age. So that would mean when we had that 2-year-old that we talked about earlier that had a hypotensive low of 74 systolic, if we drop below that, then we would go ahead and pop positive here. If they're tachypnic for their age, if they have altered mental status, so GCS of less than 15, it's a pretty quick way to just say there's something going on with this kid, and it could be, if I have a source of infection, then it could be septic related. And it's helpful to use pre-hospitally, but then also in the ED when you first get patients in, because it's all very easily attainable information, right? Versus our SIRS criteria is a little bit more involved. It's more of a triage tool to help determine patient acuity and identify patients, again, that are potentially septic and need further screening. But you need to have at least 2 of these criteria in order to qualify for it. And like I said, some of it's not easily accessible. So like temp, you may be able to get a temp pre-hospitally, but let's say it's winter and you can't get an axillary temp and you want to get a rectal temp, but you're 5 minutes from the hospital and you don't want to unbundle this kid to get this rectal temp. And so it can be a little bit more challenging. And then abnormal white count or 10% bands, you can't assess that in the field, right? And you can't assess that as soon as somebody walks into the ED either. It's going to take some time to send labs off and get information back. So this one can be helpful maybe a little bit later on, but QSOFA is a nice quick one to be able to run through and say, all right, my systolic's low, my respiratory rate's high, and I've got altered mental status, and I have a cause for an infection. I have a source. So I'm going to put that together and say that this is a high potential. And then hypovolemic shock, like I just kind of touched on a minute ago. It's not uncommon in our pediatric population, especially because of how poorly they handle dehydration. So either it results from what? Extensive fluid loss or hemorrhage, right? So the most common cause, at least in pediatric patients, of hypovolemic shock is diarrhea and or vomiting secondary to some kind of a GI illness. So this is where our assessment and history become really important. So let's say you've got a 8-month-old, right? They're febrile, they have a tempo 101.5. Their heart rate's 220, their respiratory rate 65. So, you know, their heart rate's up, their respiratory rate's up, they have mottled hands and feet, their cap refill's poor, they're irritable, they're crying, but they don't have tears. Mom can't console them. You can't get a blood pressure. You know, what do you want to do? So here's kind of a cool chart that I found. Obviously, you know, I know we don't have this posted anywhere, but it's kind of a good one to review and see if you can remember some of the pieces. But we've already talked about heart rate, cap refill, peripheral pulses. But what do our mucous membranes look like? Are they dry? Are they cracked? Are they moist? In this kid, I would guess no, they're not moist. What are our fontanelles like? Is it sunken? Mom tells you that the child's been vomiting and had diarrhea for 3 days, hasn't been eating or drinking well. Last wet diaper was from, you know, the day before. She's not even sure what time, but it's, you know, 4 o'clock in the afternoon today, and she hasn't changed the diaper today. So what do we do, right? First thing that we want to start here is to fix that fluid loss problem, right? So that's where we start doing the 20 mLs per kilo fluid boluses. And then we want to reassess. So we would do a bolus and then we reassess. Did our vitals improve? Did our cap refill improve? Did the modeling improve? Yes or no? If it didn't, maybe we consider doing a second bolus. Maybe we even consider doing a third bolus, depending on how severe their dehydration is. So we don't want to be afraid of giving fluid to kids that are showing signs of hypovolemic shock. And that's why this is so important. That no tears thing is usually a pretty good indicator that they are very under resuscitated and that they could benefit from a little bit more fluid, because it takes a while through this process before you start seeing no tears, especially with the pretty aggressive crying that some of these kids were able to do. So how about we, you know, have all of these things. We know about all these disorders now, right? But we have a child come in, they're in extremis, and we need to do some med administration. And we know that everything's weight-based. And because it's weight-based, it tends to be small. And when it tends to be small, it tends to have to be in smaller syringes, and it can be a little bit more challenging to draw up. So how do we do that? So stopcock method for drawing up medications is the best practice for drawing up pediatric medications. And as we talked about, they're all weight-based. You take their weight in kilos and then you multiply it by whatever the dose is. So for example, let's say we've got epi on the screen. We'll talk about epi. We've got our code epi syringe. This is standard 1 milligram and 10 mLs. And so let's say you've got a 32 kilo child, right? And they're in cardiac arrest and you're in charge of getting the epi together. And then here's actually something that's really kind of cool. Only works with epi, okay? Only works with the code syringe epi. So 1 milligram and 10 ml, and it only works if your weight is in kilograms. Never works with pounds, only with kilograms. So what you can do is you take your 32 kilo kid, okay, and you move the decimal point 1 place to the left. So you've got 32 kilos, move it 1 to the left, that makes 3.2. 3.2 what? That's how many mLs that you would give out of this code syringe. And it works for any sized child with the code syringe and their weight in kilos. 18 kilo kid, 1.8 mL. 7 kilo kid, 0.7 mL. 22 kilo kid, 2.2 mLs. All you have to do is move that decimal point 1 place over, and that's how many mLs that you would give from this code syringe. You also have it on your Brasil tape, so don't forget about that. And then we have binders on all of our PD carts here in the hospital that you can actually turn to the weight of the child, and it has all of the drug information as well and how many mLs that you would need to give. So it can be a helpful thing to just have a quick in the moment, or to just confirm with yourself that you know that you're in the right page. But best practice for drawing up pediatric medications from pre-filled syringes especially. So that would be our epi, atropine, calcium chloride is another one that we have, is to use the stopcock method. So you can see here in the picture, you've got these 3 items, and I have them here, but I know my camera is a lot smaller when I'm sharing the slide. But what you'll see is you have your epinephrine, and then you have an appropriately sized syringe. So for example, if you're giving less than 1 ml, you want to use a 1 ml syringe, because then you'd be able to pull a much more accurate dose up that way. If you're giving between 1 and 3 mLs, then you'd use a 3 ml syringe. And if you're giving between 3 and 5 mLs, you'd use a 5 ml syringe. So what we would do is we would use our appropriately sized syringe. And then we also need to have a stopcock. Now in the ED, we put the stopcock in our PD drawers. If you're working pre-hospitally, you just want to double check and see where you have one of these easily accessible to be able to use for this. And then what we would do is when we have our stopcock, you can see here in the picture, it comes preset so that it's off to the port that would normally connect to the IV that would connect to the patient, because we don't actually want to use this piece at all. Okay, we only want to use these other 2 ports. So we're going to leave it off to that section that we're not using. Okay, and then what we do is, you can see here, you connect your syringe to one port, and then you connect your code syringe to the other port. And it doesn't matter which syringe connects to what, because it's just going to be a push-pull, and that's all that we're really focused on. So one goes on here, pretty simple, and one goes on here. Okay, and then from there are 2 things that you can do. So you know that you're off to the port that you're not using, which is great. If you turned it off to here, then now this syringe is communicating with this, so it's clearly not going to do anything. And if you turn it off to here, then the code syringe is communicating to something that we're not using. So that's why it's important to keep it off to the port that we're not using. And then you can do one of 2 things. You can either start pushing up from your code syringe, and you're going to see fluid start to enter here, or you can pull using your smaller syringe that you're pulling your dose up into. Now, what I tend to do is I overpull, okay, because I'm stressed and there's a lot going on, and I'm not going to have the steadiest of hand when I'm doing this very first time. So I overpull, and then I go back and I just push up to whatever my dose is going to be. Okay. Then from here, I can go ahead and disconnect, and now I have a code dose of the medication that's weight appropriate for that child. And now afterwards, when I need to do a 2nd dose or a 3rd dose or a 4th dose, I can just go ahead and clip it back on. So let's say I use this, clip it back on. Now I can go ahead and pull again. Okay. And the more that you pull from this, sometimes the more air that come out. So if you start pushing like this and you see there's a lot of air and you're like, oh God, I can't get this air out, just turn the system. Okay. Let gravity help you, and it'll let some of the air stay back in the syringe, and then it'll only allow you to pull fluid. So again, this is the best practice. I highly recommend you doing it this way, because it does make it a little bit easier to keep track. The other thing that I've seen people do is they will take the epi vial part. So, you know, when you pull it out of your container, you've got this piece that connects to your top portion hub, right? They'll pop this off, and then they'll just put a really big blunt needle on the end of a syringe, and they'll actually just put it down in here and get it through that rubber. But you can see once you start using it and you get down to less, that's a lot of space that you have to try to put that syringe and the needle through. And I've actually seen these break, because, you know, this is protecting it when you put it on, right? And so if you hit it at the wrong angle or put too much pressure on it, you can actually crack this. And then your risk of poking yourself with a sharp is a lot higher, because you're trying to aim it into here to pull out the medication. So this way is the safest, and it is the best for getting the most accurate number off of your syringe. Okay, so let's just kind of, there was a lot there. So let's just kind of go over some of the takeaway pearls one more time. So normal vitals in kids, right? They change depending on their size and their age. Just make sure you know what's appropriate for the child that you have in front of you. There's a lot of resources out there, so use whatever is easiest for you to get your hands on, and that way it'll help you to guide your care and make you feel a little bit more comfortable with that patient you have in front of you. Hypoxia. Hypoxia is the leading cause of cardiac arrest in pediatric patients. So the recognition and treatment of respiratory conditions, especially ones that are amenable to simple measures like repositioning, oxygen, nebs, Those are the major goals in pediatric management, okay? Because of that large surface area relative to their size, they're really prone to hypothermia, especially infants and little children, and insensible fluid losses. So keep them warm and intervene if they haven't had wet diapers, they're crying without tears, they have sunken fontanelles, or they're showing signs of dehydration. Tachycardia and poor skin perfusion are the initial signs of shock in children, so they need to be recognized early and managed and closely monitored. In kids, hypotension is a late sign, so we don't want to wait until we see them become hypotensive. We want to act early on. So if we see that poor skin perfusion, again, those sunken fontanelles, signs of dehydration, we want to intervene. Always get a full set of vitals, including a temp and a weight. And anytime they have a GCS of less than 15, always get a blood sugar. Make sure that that's not part of our problem, because that's something that we could actually easily fix. And then take a minute and just kind of get yourself together. You know, pediatric patients are really stressful. They can't tell us what's wrong. Parents are really anxious and overwhelmed. There's a lot going on. We don't see pediatric patients terribly often, so it feels really overwhelming on our side. Just do your ABCs. You know, make sure your airways patent, they're breathing safely and appropriately. Check their circulation and intervene if you need to. Check out their disabilities, so their neuro exam, and see if it's something that we need to be concerned about, and expose them to make sure that you can see what's going on with them. You can see those retractions, you can see that modeling, and then cover them back up. But, you know, you do that, and then you combine that with the history that you get, that sample history, and you do a nice focused assessment on the things that you've found, and it's going to get to you to what you need. There's a couple of references here that you can go ahead and look up. When I post this video later, you'll be able to pause it here. You could do a snapshot on your computer. But these were some of the sources that I used for this presentation, but really great information out there about pediatric management and, you know, the treatment of pediatric patients. And so I highly encourage you, if there's anything that you're wanting more information about, to go ahead and look up these, or reach out to me if there's something that you want to discuss